Hello, students. We're going to do chapter 14 now. This is the newborn with the perinatal injury or congenital malformation. When we're discussing these, sometimes the collective term is birth defects, but these are abnormalities that are apparent at birth, and they may be structural, functional, or metabolism. A lot of these they're born with, that were genetic, that happened during development or at the time of fertilization. And sometimes these could result in a physical or mental disability, or may shorten life, or may even be fatal. So we're going to kind of start bleeding into pediatrics just a little bit. You're going to spend more time learning about these things as we move into the next class, the next course, but we're just going to hit some of the highlights here of the ones that can be seen at birth. So classifications are malformations that are present at birth. They also can be called congenital malformations. Sometimes they're inborn errors of metabolism, disorders of the blood, chromosome abnormalities, or perinatal injuries. And that's what happens at the time of birth. So one of the malformations we see at birth are neural tube defects. The two that we're going to discuss are hydrocephalus and spinal bifida. Hydrocephalus is characterized by an increase in the head size. There's water around the brain, and it causes pressure against the skull. And because those bones are not fused, it allows the head to become larger. And this is a pretty common birth defect in that we see this pretty frequently associated with other disease processes. So lots of different syndromes also come along with hydrocephaly. So this manifestations depends on the onset and severity. You're going to see increase in head size. Those cranial sutures sometimes will separate to accommodate the increased fluid. The scalp can be shiny. The veins can be dilated. Those are classic signs of hydrocephalus. And this is one of the reasons that we want to do a good measurement of that baby's head. So if we suspect hydrocephalus, we'll be able to measure and see that it's grown in centimeters in the next day or two. So we might see increased blood pressure, increased pulse rate, decreased respirations. There could be a high-pitched cry, poor feeding, vomiting, irritability or lethargy, and bulging fontanelles. So every time we are doing our assessment, we're running our hand along the top of that baby's head very gently to see if there's a bulging or a sunken fontanelle. Bulging could be a sign of infection, could be a sign of hydrocephaly, or and sunken could be a sign of dehydration. So the way this is treated is there's a surgical procedure that places a tube up into the ventricles of the brain and drops that down through, it's under the skin, into the peritoneal cavity, so this excess cerebral spinal fluid can drop down into the peritoneal cavity and not put pressure against the brain. So that's just a glimpse into hydrocephaly. I would like you to know the major manifestations, because these are the kinds of things that we would be finding right after delivery. The next we're going to talk about is spinal bifida. This is our other neurological tube deficit or defect that we see. And there are three different ways of seeing this. We might actually see where there's a defect here and there might be some dimpling or just a little patch of hair. I have a picture of that for you. Or you might actually see where the spinal cord pouches out into an enclosed pouch outside of the body, or you could actually see where the spinal cord protrudes outside of the body, and all of these need to be fixed surgically. So this is a congenital embryonic neural tube defect that there's an imperfect closure of the spinal vertebrae, and we might see hidden, or it might be in a sacral cyst. So this is an example of a culta, and often we do see a big patch of hair there. And sometimes as a newborn, it'll be down here in this little groove. And so we want to open that space and make sure that we don't see a little tiny opening. That's one of the assessment findings that we're looking for. One of the big ways to prevent spinal bifida is folic acid. And these are all foods that are high in folic acid. And we want to make sure that women are taking high amounts of folic acid before they get pregnant. That's the most important part, so that we have a decrease in these neural tube defects. So the next picture is of surgery. And this is how they're actually treating it embryonically. This is surgery on a fetus. So here's the uterus, here's the fetus, and here's the spinal bifida. And so there sometimes we'll go in and actually surgically fix this, replace everything. And because the fetus is still growing and being supported by the mother, they actually can, this baby can have a pretty good result. They'll put everything back together, let this mom stay pregnant, and depending on where it actually is in the spinal cord, there may or may not be any huge deficits once the baby is born. There's a really good PBS special right now called Twice Born. I think you can see it on Netflix, that talks about fetal surgery, and this is one of the surgeries that they do. So again, this is the outpouching of that spinal cord. It's a neural tube defect, and they can surgically repair that while the baby is still in uterus, and help that baby to have less defect when at birth. The next defect that we're going to be looking at is cleft lip. Cleft lip is a very common defect that we see. Most of the time, if women have had prenatal care and have had ultrasound, we will see this diagnosed early on. Sometimes it's hereditary. Sometimes there are environmental factors like exposure to teratogens, things like pesticides, that sort of thing. And it appears to happen more often in boys than girls. Initial repair will happen at about 3 months of age. So if mother and father know this is going to the baby's going to be born with this, we let them know when the initial repair is going to happen. There will be some specific interventions that need to follow as far as nursing care. They're going to have elbow restraints to keep them from picking at the sutures or scratching where it's been repaired. And they will be fed with either a special syringe or a bottle as the mouth is healing. And here are some pictures. This is the baby born with a cleft lip, and you can see it's been repaired here, and there will be a couple of more surgeries required. This is right after surgery, and these are the picture of the wrist restraints, and that's just, or the elbow restraints. That's just to keep the baby from bending their arms and putting it up towards their mouth. So this can actually be fixed, and these babies do very well. Sometimes their teeth, their dentition can be affected, and they might have to have further surgeries as they grow and as their mouth grows and as they move into adulthood. So we want to make sure that we are going to prevent this baby from crying and sucking as much as possible after surgery, and careful repositioning. We want to prevent infection to decrease scarring. Want to definitely hold and cuddle this baby and provide pain relief measures. As I already discussed, we would be using a dropper or some sort of special syringe or bottle, and we want to keep that site very, very clean. The next condition we're talking about is cleft palate. Sometimes you'll have a cleft palate without a cleft lip, like in this picture, and sometimes cleft lip and cleft palate will go together. And that's just early formation when the baby, the fetus was turning those neural tubes over and connecting. Sometimes they don't have full connections. So there are increased risks of infection. Sometimes these babies will constantly be spitting up milk out of their nose. So as part of our initial assessment, we're looking for this opening in the palate. The most common condition we see is called club foot, also called Talipes equinovarus. It is where the feet turn inward, and it's usually based on positioning of the womb. And if we don't help these children to fix this early on, they won't be able to walk correctly. So we can utilize some splinting. Most of the time, surgery is not required for these. It's generally both feet that are involved, but it needs some specific splinting like this. That will help this baby, because the bones are so soft and the muscles are so soft. We can help fix this in just about 3 months. If we don't fix it in the first 3 months, then surgery is most likely going to be necessary because it has calcified and formed that way. Also, passive stretching exercises. This is when you have a good occupational physical therapist that will help the parents develop this plan. I've seen some pretty severe deformities that are completely fixed by utilizing some good splinting and some exercises within the first couple of months. If it is not fixed and they do have to have surgery, here are some of the different harnesses and traction that may have to be utilized. This is typically utilized for congenital defects of the hip. And I must have skipped a slide there. So this is looking at the different traction and Pavlik harnesses and body casts that can be utilized for congenital hip dysplasia. So some of the other problems we might see are inborn errors of metabolism, and these are going to be signs and symptoms that present early on, but we're not going to know for sure what these are until we get that newborn screening test back. The biggest one that we see is phenylketonuria, and I'll talk about that in the next slide. But some of our symptoms for some of these metabolic defects are lethargy, poor feeding, and poor tone, tachypnea, vomiting. Sometimes maple syrup urine disease is what this one is referring to. But these babies have some sort of metabolism error, and we can fix it typically with either diet and or medication if we catch it early enough. And that's the purpose of that screening tool, the newborn screen that we do with the 5 or 7 little circles of blood. So phenylketonuria, or PKU, sometimes you'll hear the test, the newborn screening test, referred to as this because this is one of the first things that it tested. But this is where there is the inability of this, there's no amino acid to help break down this phenylalanine. And it's found in a lot of foods, and so we have to change this baby's diet very early on. If we don't fix this or catch this early, severe mental retardation can happen. And so, but it can be completely monitored and managed with a good diet. So here's that newborn screening. This is an old picture. There's now 7 circles. And this is a picture of where we actually would utilize to poke this baby's heel on the edges here. I always say that you put your thumb in this area, and everywhere that your thumb is not touching is where you could go. And the reason for this is because we don't want to hit the nerves that are right underneath the skin here. So treatment is close dietary management. We want frequent evaluation of the blood levels, and there will be some specific foods and formulas that will be made for this baby that has found to have PKU. So here are high phenylalanine foods. It's all the foods we typically tell parents to feed their children, and these are low phenylalanine foods. And then we have to make sure that we are watching certain sweeteners. Artificial sweeteners have PKU in them. Most gums have PKU in them. I'm sorry, have phenylalanine in them, and PKU is the inability to process that. So we want to pay very close attention to food labels, and these parents will need ongoing support with their pediatrician if their child has this. The next disease process we're going to be talking about is Down syndrome. This is the most common chromosomal abnormality. We see higher risks in women that are older, so when their eggs are older, 35 or more, and these risks significantly increase after the age of 40, and also fathers after the age of 55. There are mental deficits, sometimes severe, sometimes mild. And there are some physical characteristics of these babies. And here are some pictures of that. So you'll see these babies, they're born with decreased muscle tone. They have excess skin at the nape of their, at the back of their neck, sometimes called a fat pad. They typically have low slanting eyes and a low set ear. That's common. Sometimes they'll have what's called a semi-increase. Other people can have a semi-increase. In fact, if you check your hand right now, I'll bet we'll find someone in the class that has a semi-increase. So it's just one of the signs, one of the manifestations of it. It doesn't automatically mean that you have Down syndrome. They might have wide, short hands with short fingers, and there might be a large space between their first and second toe. Some babies have all of these symptoms. Some of them have very few of them. There are a couple of different phenotypes. The most common is trisomy 21, where there are 3 numbered 21 chromosomes instead of the usual 2. And this is a result of a failure to separate. So every gene in the body has this third chromosome. Sometimes there's a translocation. So part of the chromosome has been moved to another area, and that can cause a problem on that 21st chromosome. And then there's what we call a mosaic, and that's where both the normal and abnormal cells are present. These tend to be less severely affected and don't always have the same physical characteristics. So screening is offered during around the 15th week of pregnancy. They call it a quad test. That's the alpha fetoprotein, HCG, unconjugated estradiol, and inhibin A levels, all used for diagnosis. Amniocentesis is the most accurate because they're actually pulling cells out. And parents can make the decision at that point, if they get a positive screening, to move on to amniocentesis, which has its own risk factors. And some parents, if they do find a positive on the amnio, decide whether they want to continue the pregnancy or not. There are some countries that highly recommend you don't consider the pregnancy. And so in certain cultures, you will not see a lot of Down syndrome babies because they are not born. In America, we don't abort all of these babies. We do see a large population of Down syndrome, and you even see them in social media and in pop culture now as they start to move into our workplace. So what we're looking for with these babies are milestones. And this is one of the things that we are paying attention to with our any baby that has a congenital defect or inborn error of metabolism is, are they meeting their milestones? And when we talk about milestones, these are the things that we expect to see. And you're going to do more growth and development when you get into pediatrics, so I'm not going to spend much time here. So our perinatal injuries are things that are caused in pregnancy. One of the number one perinatal injuries that we see is the Rh negative mother and an Rh positive father who produce an Rh positive fetus. So we've talked about this before, and here's another picture of what I've described. If baby is positive and mom is negative, there may be antibodies produced, and the next pregnancy will be affected. And so this causes severe anemia in that next pregnancy. And so we are on the lookout for Rh negative mothers who have not received RhoGAM. And if they've not received prenatal care, or they've had miscarriages or abortions for babies that were Rh positive, they may be sensitized. So we are watching for Rh disease. Jaundice occurs jaundice that occurs on the first day of life. I talked about jaundice in the last section in chapter 13, is usually indicative of some sort of Rh or blood incompatibility. This is what we call pathological jaundice, and it's very severe. And we have to intervene immediately so as to prevent kernicterus. Intracranial hemorrhage is another issue that we might see with our babies, especially our preterm babies. If they've had difficult deliveries, there might be skull fractures. They might develop cephalohematoma up on the head, or even bleeding in the brain. This is one of our biggest problems with our preterm babies, is bleeding within the brain, which can cause long-term deficits. It can cause seizures. It can cause cerebral palsy, or cerebral palsy might result from this. And so we really want to be careful with these babies' heads during delivery. Instrumental deliveries, things like vacuums and forceps deliveries, do increase the risk of this. Meconium aspiration syndrome is where the baby has actually breathed in some of the meconium that was floating around in the fluid, and this can act like glue in that alveoli, and it can cause an entire syndrome, including respiratory distress syndrome. We are trying to avoid this if at all possible. There have been lots of different changes into our evidence-based practice over the years. And we're kind of at the point right now where they will go down and suction very deeply if the baby's born with very thick meconium, trying to avoid the baby aspirating and breathing that in. Signs and symptoms of meconium aspiration may not happen right at delivery. They may happen over a period of hours following it. You might see respiratory distress, nasal flaring, retractions, that central cyanosis again, grunting. You'll hear rales and rhonchi, and tachypnea may persist for several weeks. They may need oxygen support. They may need supportive care. And if we suspect meconium aspiration syndrome, they will be in the NICU. The next issue we might have is our neonatal abstinence. Any baby born addicted to anything, whether it be alcohol, whether it be nicotine, whether it be caffeine, all these or some sort of opiate, these babies are going to have to withdraw from those substances. These are little humans that have the same addictive properties that we do, and whatever they're exposed to in the uterus is going to affect them. So we sometimes have to help them withdraw. There's a really good video in this week's YouTube video group of a program where these babies go into a special NICU that helps them withdraw from these drugs. We might use a neonatal abstinence scoring list to see if they need treatment. And so again, this is an assessment that we do to look at the different signs and symptoms of abstinence syndrome, and if they reach a certain score, we might have to treat them with medications. So some of the things we might see: body tremors, irritability. These babies don't respond to the same kinds of comfort techniques that we would use with a baby that has not been exposed. Wakefulness, severe diarrhea, excoriating diarrhea that actually burns the skin on their bottoms. They're poor feeders. They do a lot of sneezing, a lot of yawning, and meconium can actually be tested for, it's more accurate than doing urine testing. And so the treatments that we try to use are swaddling, keeping a quiet environment, observing for any seizures, and we might give them phenobarbital or other medications to help get through this abstinence. And it can take several weeks for some of these babies. We've talked a lot about the infant of the diabetic mother, so I'm not going to spend much time here, but you can see this baby is going to have lots of other issues. Here's a picture of a baby that is from a very poorly controlled diabetic mother. It needs respiratory support, feeding support, IVs to maintain blood glucose, obviously in the NICU. We are going to be doing lots of things to help this baby. They have a higher risk of hyperbilirubinemia. They have a higher risk of respiratory distress syndrome, and lots of care goes into taking care of these babies. So we're going to be looking for glucose levels, vital signs, signs of irritability, tremors, and respiratory distress. If you have any questions, you know where to reach me.